Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I have the pleasure of speaking with Dr. Paul Leong, a pulmonologist and sleep physician who founded Smileyscope, a virtual reality approach to decrease pain from medical procedures. Dr. Leong is going to tell us where he got the idea, where he is in development, and how this new technology works. But before we get started, I'd like to thank our sponsor, locumstory.com. If you're considering locum tenens, either full-time or on the side, you probably have a question or two, or 20. Fortunately, Locum Story has the answers you need. It's packed with unbiased information and advice from physicians like you. Locumstory.com has nothing to sell. It's simply a resource for information. You'll find super handy tools that let you see locums trends for your specialty, compare different locums agencies, and there's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. And now, without further ado, I'd like to welcome Dr. Leong to the Art of Medicine. Dr. Leong, thanks for joining us.
Thank you, Dr. Wilner. It's a pleasure to be talking with you.
Yeah, well, thanks for joining me. I heard about this Smileyscope thing, and I was impressed and baffled and didn't, virtual reality, we hear about it, but I actually haven't seen much in the way of really real-world application. So maybe this is it. So I want to work up to that. Tell me what is your medical background and how that led you to Smileyscope.
So I'm Paul Leong. I'm a board-certified internist, pulmonologist and sleep physician in Melbourne, Australia. And for the first 10, 15 years of my career, I dedicated it to the science of medicine. Like most of us in medical school, I was trained thoroughly in the arts of making sure that we got the science correct. We were making sure that we were technically correct. We were making sure that we were driving towards outcomes that mattered mostly to us, morbidity and mortality. And throughout the first 10 to 15 years, what I did was I really honed my technical skills. I was very interested in interventions. As an interventional pulmonologist, I did a lot of things that were quite uncomfortable to patients, thoracic ultrasounds, putting needles and ICCs into chests, doing ultrasound-guided procedures, bronchoscopies, all kinds of things. But throughout time, it dawned on me that there was more to the science, but there was an art of medicine as well, just as you have identified. And along the way, it occurred to me that when I was looking after a patient with cystic fibrosis, that sometimes we were maybe not doing the right thing by the patient. And so I had this incident happen to me about 10, 15 years into my practice, where I had a man with cystic fibrosis come into my care. He was admitted on the acute ward service. He had been so heavily traumatized by procedures and by his childhood medical care that he totally omitted to attend his preventative care. And so he came to me in a health catastrophe, a health crisis, and needed a tune-up. But all of those factors that had contributed to him neglecting his care really came to a head at that point. He was extremely phobic of needles. He was extremely phobic of procedures. He was extremely phobic of absolutely everything that we wanted to do. And as a result of that, every 3 days for an entire 3-week period, I had to book him a nitrous sedation just to change his cannula. And I thought that is an absolutely crazy level of intervention for something that should just be a simple procedure. And it dawned on me that this was the pointy end of the art of medicine, that we had done the wrong thing perhaps by focusing on the science, by focusing on the outcomes that mattered to us. The forced expiratory volume in 1 second, the CRP, the sputum colonization, whatever it happens to be, sputum microbiology. But for this particular individual, the thing that mattered most to him was his experience of healthcare. And I think that's where the idea for Smileyscope came along. So for me, Smileyscope was a very personal journey. I had been looking after this man, and I wanted a tool that I could use to solve this at the bedside, to prevent this from happening in childhood, and something that I could not only use for myself, but give to other clinicians to solve this issue that I'm sure that all of us have seen on numerous occasions. And so we started developing Smileyscope out. We did a systematic review, meta-analysis. And at the times, a few years ago, there was really nothing that was suitable for use in my clinical practice. The types of virtual reality visualizations that were available were really not appropriate for children or young adolescents, or even in some cases adults, to be perfectly honest. And so we developed a new way of doing virtual reality where we matched what was happening in the real world with what happens in the virtual world. And we ran that through 2 large randomized clinical trials, and we found it very effective. But what we also found was that as we were doing those clinical studies, clinicians were taking the virtual reality headsets and using them on patients that we hadn't intended. And then when we came to close out the clinical study, what we found was that the clinicians were saying to us, hey, can you leave these sets just a little bit longer? These are really effective. And it was at that point that we knew there was something in this, that this problem was not a problem that just resonated with the patient, didn't just resonate with me, but resonated with the clinical community. And so we commercialized the idea out in Australia, and within 10 months of launching in Australia, 100% of pediatric hospitals there were using our product successfully. And on the back of the systematic review and clinical studies, we now have a guideline recommendation from a vascular association to use Smileyscope for needle pain. And so the next step for us is to think about, how do we make this happen in the United States? We know in medicine there's often this evidence gap. We've generated evidence, we've seen tremendous real-world clinical benefit, but how can we make that benefit be seen to the millions of people in America who undergo needle procedures every year?
Wow, that's fantastic. You said so many things that resonate true. One is the experience with chronic illness. You know, we don't, if you don't have a chronic illness, you don't think about it. But for example, in my hospital, we have a lot of sickle cell patients. These are patients that are in and out of the hospital with crises, with pain, you know, for their whole lives. And it's not uncommon for them to develop an antipathy for the experience. And if there was a way of ameliorating the pain component, you know, and of course, dentists know this. You go to the dentist, if they don't sedate you, you know, you're out the door, right? And children, you know, my boy, when we drive to the pediatrician, he's little. It's like as soon as he recognizes the parking lot, you know, he's out of there. He remembers the needle experience. You know, the little kids get so many vaccinations when they're young that's the big takeaway from going to the doctor. And so why should pain have to be part of the experience? And thank you for focusing on the art of medicine. Yeah, so you have a technology. Can you tell us a little more about the tech? In other words, you said that the virtual reality reflects what's going on in reality. So expand on that, please.
Great. So the way we developed this, we now have a suite of virtual reality visualizations which can match the vast majority of procedures that we do in acute medicine. So initially what we did was we focused on that acute needle experience. So short needle procedures like having vaccinations, intermediate or shorter duration procedures like cannulation and venipuncture, and then longer experiences like ports. And what we did was we measured the average timings of the procedures, and we wrote storylines to match those timings. And so on average, we know it takes a certain amount of time to check your ID, to draw up the medication, to do the antiseptic or the tourniquet, to palpate, and then insert the drip. And we've matched the timings along the way. On top of that, we've also been able to configure the virtual reality experience so that if you're doing a needle procedure, for example, on the abdomen, or you're doing a burns dressing on the legs, we can configure the virtual fish that nibble to come up at the corresponding place. And so that's how we match the virtual reality to the procedure. And we have done it in a slightly different way to most people. We've done it so that the headset actually generates audio that can be heard throughout the room. And this is really important from the pediatric context, as well as from the procedural context, because from the pediatric context, what you want is for the parents and the caregivers to be able to participate in the procedure with the child and support the child, not isolate the child using headphones, right? And so when the patient or the child is going underwater, the parent can do the comfort positioning, hold the child and say, can you, they can hear the fish coming along. They can say, hey, what's your favorite fish? And participate in that. And the audio allows the proceduralist to synchronize the procedure at the right moment.
Great. That was my question. So it's not a scenario where the kid can wave his arm in the virtual reality and something actually happens outside. You've synchronized everything by letting the room hear what the child sees. And that program has its own, it's like a recording, I guess, right? It's going to play out. Is there a way to pause it? Or, sometimes you drop something, you got to take a break. Is there a way to control what the child hears or sees?
At the moment, it plays the video. It plays in a predictable fashion, and we have technology coming where we will be able to alter it and do that kind of thing. But at the moment, it plays, and if the procedure takes longer than necessary, it loops. So the way that the experiences work is that we typically we develop them in partnership with children, child life therapists, psychologists, pain specialists, and pediatricians. And we asked children, where do you want to go on your adventure? And they pretty much uniformly said underwater. And then how do you want to reimagine the needle as a fish? And it was pretty much uniform. We got some really interesting answers, but they were the most common ones. And so it starts with guided relaxation, guided breathing, hypnotic suggestion. And so the child feels calm, at ease, adults too. And as they go on the adventure, if there is, for example, you accidentally drop your equipment, or you find you're out of stock of the particular gauge cannula or whatever, and you're rummaging around in the drawer, there is a window where you can do those procedures as well. So it's very flexible, and it's very, very effective. We've been used in statewide COVID vaccine rollouts in Australia, and been very successfully used there. So I do think that it's a technology with widespread application.
Now you mentioned you did some studies. So how do you study effectiveness of a short procedure, and I guess the tolerability of that? There's the screaming level, and how long did the screaming last? But you probably had some more precise measures than that when you did your outcome studies. What outcomes did you look at?
That's a good question. So what we did was we ran 2 RCTs. When we were starting this journey out, what I said to myself is, when we did the systematic review and meta-analysis, the studies that were there were really small. I'm talking, 10 patient, 20 patient, sort of really, really small studies. And what I wanted to do was I wanted to definitively see, does this make a difference or does it not? And because of my background in public health, I wanted to make sure these were the most generalizable studies possible. And so that's why we ran 2 studies. We ran one in the emergency department, and that's looking at, patients, routine children aged 4 to 11 years old, based on the primary measure that we used. And these patients were a little bit more unwell because they were presenting to emergency department and they had some pain. As well as that, we had an outpatient phlebotomy or outpatient patient pathology study. And these patients were generally well and ambulatory, and they had no existing baseline pain. And then we entered them into the study, screened them, and we had set very broad inclusion criteria because we wanted this to be a very generalizable study. And then they were randomized to virtual reality or to standard of care. It's not possible to blind virtual reality. I don't think anyone has ever been able to do that. So it's an open study. And what standard of care was, this is not a placebo. It's not ethical to do nothing when you're talking about pain. And standard of care was a bundle of care at these tertiary hospitals that we worked with, which included topical local anesthetic and age-appropriate distraction, which was tailored to the child by the clinician and the parent in the room. The primary outcome was child-rated pain. So you ask the child, what's your pain? And then you see what they say on a validated scale called the FACES Pain Scale Revised. And what we found in the studies was that there was a consistent benefit for this virtual reality solution, that it outperformed that tertiary hospital standard of care, reducing pain. But what was interestingly was that we found that there were really powerful reductions or benefits in the pre-specified secondary endpoints of anxiety, maximal parent-rated distress, and really interestingly, the need to restrain children. So we just about halved the need to restrain children or hold them down for procedures. And I think that's really important. If I think about the first patient that I talked about, that young boy who grew up to be a young man whose entire life trajectory was distorted by this procedural fear of needles. And so if we can give people better needle procedures, reduce pain and reduce anxiety, I think that's a really good thing.
I think that's a terrific endpoint because it's so objective. You know, we need to restrain or not. And of course, that's a big deal. When did you ask about the pain? Was it, 1 minute after the procedure was over, or during the procedure, or 5 minutes later? When did you get that data point?
So we asked them about their baseline pain immediately before the procedure, and we asked them at the end of the procedure, what was your maximal pain?
Okay. And, I can imagine using this as a neurologist. We do lumbar punctures, which requires basically a needle stick, but it has a lot of anxiety associated with it. And people see it as a much more major procedure than in reality it actually is. So some sort of calming visuals. I don't know if a fish would be the best avatar for the needle, but we come up with something that people would relate to. And, even if the anxiety drops by half and the pain doesn't even change, that's still a positive outcome. Make people more comfortable to get them through the science, right? We need those samples. We need that IV. I mean, that's why we're doing it. But diminishing the suffering involved in the process sounds like a terrific idea.
And Dr. Wilner, lumbar punctures were very much in my mind when we were developing this. As a resident, I used to run a lumbar puncture list every week, and I think that was a real thing. The fear and anxiety around having a lumbar puncture. And in my last run of ward service, I was on the weekend, and there was a return traveller from a Southeast Asian country who had a fever and a headache and needed a lumbar puncture, but was extraordinarily needle phobic. And I had to provide him sedation, which I administered just to get that done. And it occurred to me that there were so many places through medicine there where the fear of something which ought to be technically very straightforward is so disproportionate. And I think that's what virtual reality can help people with, at least the way that we've been implementing it is at that acute bedside at the time where that fear of pain and anxiety is just so prominent. And I found myself when I was giving this person midazolam and all the kinds of things, I just thought, I wish I had virtual reality right here. So, I think that we can use the virtual reality visualization we've got for lumbar puncture, but there are so many procedures besides medicine that we still need to explore.
I think it would be great for the waiting room, right? People are anxious. You go to see the doctor, and it'd be better than a magazine. So what are the hoops you have to jump through to make it's not a drug. It doesn't sound like the FDA has to approve it, or does it? What are the hoops you have to jump through to make it available in the US?
So in Australia and the EU, the Smileyscope device is a Class 1 medical device. And in the US, the Smileyscope can be currently sold under the Mobile Medical Applications Framework. And it is being successfully used in a number of hospitals and private practices around America at the moment. There is a to make the claims that we make in other jurisdictions on reducing pain and reducing anxiety will require an FDA application because that's the regulatory framework in the States. And so we are currently going through the motions of thinking about a Class 2 application to say, so that we can definitively market to say that we do reduce pain and anxiety, as we've seen in our RCTs and as we've seen in our post-market studies as well.
So if I want one, can I get one, or do I have to wait?
You can get one if you'd like. That's correct, yes. And so now, interestingly, the product has grown significantly beyond that initial needle experience that we grew. We have over 24 experiences. We've got languages including Spanish. Last year, Sir David Attenborough joined the platform with a palliative care forest meditation. And so now we have an entire suite of experiences that runs the gamut from age 4 all the way through to literally end-of-life care. And so I think we are really finding powerful ways to change outcomes for the better in acute medicine. We're being used in the National Health Service in the UK to help with miscarriage procedures, and I think we're running a randomized controlled trial looking at vasectomy in adults at the University of Miami, and so I think there are just endless applications for this.
And I can't visualize any side effects. Are there any adverse events?
So in our studies, we did not find any significant adverse events. In fact, in the children who did not have virtual reality, that's the standard of care children, they had more effects. They were more nauseous, more afraid than individuals with the virtual reality. But speaking more generally, most of it comes down to how you design your virtual reality. You can induce a sense of disequilibrium if you have the viewer move through the world in a way that is not matched by their oculovestibular system in the real world, right? If they sense illusory motion while they're sitting still, people find that quite nausea-inducing. So a lot of it comes down to the design of the virtual reality. And in the remainder of the experiences that we've implemented, we've been very, very careful to ensure that we have experiences that do not cause any nausea. But apart from that, really, there are no major adverse effects for this.
I guess there's a headset that you wear. Is that right?
That's correct. And so the way that we've done this is quite different because we were looking for a solution that worked in our clinical practice. We developed our own bespoke hardware, which is infection control compatible. So the headset that we have contains no fabric. It is impregnated with an antimicrobial compound, which ensures that it remains clean for the next patient. And You put the headset on, it's very easy to adjust. And the way that you configure the virtual reality in our system is quite unique when you compare it to other systems. So you take off the faceplate, that's you, the clinician. You can use a touchscreen just like you would on a smartphone to configure the virtual reality experience. The plate just snaps on with a magnetic closure, and you press a single button to calibrate and start. And so that is 5, perhaps 10 times faster than any other system on the market. And for children, it has really specific advantages because you can't expect a 5-year-old child to use a current virtual reality headset, because that would ask you to log in, to calibrate the set, to choose the appropriate program, following which then you need to wipe it down, rest it, put it on the child, and then have it all start. So that would slow down your workflow. So this way that we've designed it basically for ourselves is really quick and effective in getting children down into and adults into virtual reality.
Yeah, well, the longer it takes to get going, the more anxiety, the more time there is for anxiety to build, waiting for the whole process to start. So quick and dirty definitely sounds like the way to go. Well, Dr. Leong, this has been great. You've shared this new device. It is available. It might soon have the approval of FDA when these studies are complete and be even more widely available in the US. Is there anything you'd like to add before we close?
No, I just wanted to thank you for having me on your show, and I wanted to thank the listeners for their attention.
Yeah, well, thanks very much. And you can be reached. The website is smileyscope.com. Is that right?
That's correct. And I'd encourage your listeners to reach out to me directly if they like. My email's Paul, Paul, @smileyscope.com.
Well, thanks, Dr. Leong. I'll put that in the show notes. Now, before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. I'm Dr. Andrew Wilner. See you next time. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests, and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com